Good evening, all. We begin with our maternal medicine module now, and we'll be covering the talks which are frequently asked in the examination. Most of the time, the SBA questions are asked from the talks. So we begin with our quote, Master MRCOG with concept-oriented clarity. We'll be finishing three talks today. The first is a thrombocytopenia in pregnancy. This talk is very frequently asked. So normal platelet count is around 1.5 to 4 lakh that we know well. Now during pregnancy, the platelet count may be reduced, and we can have this thrombocytopenia graded as a mild, moderate, or severe. Mild, if your platelet count is between 1 to 1.5 lakh. Moderate if it is between 50,000 to 1 lakh, and less than 50,000 we call it as a severe thrombocytopenia. Generally, the patient will be asymptomatic. Patient will have symptoms if it goes below 50,000. Okay, so you remember this from SBA point of view. Then let us see what is the prevalence of this condition. It is relatively common, around 1 out of 10. So 8 to 10% pregnancies are known to have this thrombocytopenia. And these percentages also you remember, 75% cases it is the gestational thrombocytopenia, while 15 to 20% it is the hypertensive disorder. That is the commonest will be your preeclampsia, HELLP, etc. That all comes under the hypertensive. So if you look at 95% cases, the cause is known to us. Either it is gestational thrombocytopenia or hypertensive disorder, and rare disorders are 5% cases. So 15 to 20% cases, it is hypertensive disorder. 75% cases, it is gestational thrombocytopenia, and remaining 5% will have ITP in 3 to 4% of cases, and 1 to 2% cases rare causes such as thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, malignancy, etc. So the most common cause is the gestational thrombocytopenia. This also you should be able to remember from SBA point of view. So gestational thrombocytopenia, and you should be able to differentiate because if the EMQs ask, you should not get confused between the ITP and TTP feature or hypertensive disorder, etc. Okay. So basically, why this thrombocytopenia happens, it may be because of either destruction is increased or consumption is increased, or there can be dilution because of the hemodilution during the pregnancy, or the production is increased at decreased at bone marrow level. Generally, in pregnancy, around 10% fall is known to happen, and this happens in the third trimester, mainly because of the plasma volume increases. Okay, so what are the differential diagnoses? You have gestational thrombocytopenia, you have ITP, then you have TTP, and hemolytic uremic syndrome, then you have HELLP syndrome, then pseudothrombocytopenia could be there, and other viral and malignancy. These are the causes. What happens in gestational thrombocytopenia? There is a hemodilution, and also there is an increase in the destruction of the platelet, but this is seen in the late pregnancy, and generally the condition is mild. Okay, you do not have a severe thrombocytopenia. The gestational thrombocytopenia has got a very specific features which we'll go into the details after this. Then you have ITP, that is there is immune destruction, and there is a isolated thrombocytopenia. Then you have TTP and HUS. Here there are microthrombi, and generally the patients will have neurological and renal signs. Then you have HELLP syndrome. Again, there is a microangiopathy, and you will have deranged LFTs and hemolysis. So these are the four common which you should know. Okay. Let us go further. Now come to the first, the gestational thrombocytopenia. Here, the most important thing you remember that it is a diagnosis by exclusion, and most of the time the platelet count is more than 70,000. Often it is more than 1 lakh. So if you have the platelet count above 70,000, unlikely that other you are dealing with. Most likely the cause will be gestational thrombocytopenia. Okay. Then there is no maternal bleeding. Fetus is not at risk. There is no fetal thrombocytopenia, generally seen in the third trimester. Okay, so if your scenario mentions the serial count, which is given the first trimester, second trimester counts, and the third trimester it is showing thrombocytopenia, most likely we are dealing with the gestational thrombocytopenia. There is no history outside the pregnancy. It will resolve spontaneously in the postpartum period, but it may recur in the next pregnancy. So it is one of the common benign condition. Now, how will you differentiate gestational thrombocytopenia from ITP? Now, gestational thrombocytopenia happens in the late pregnancy. Platelet count is generally more than 70,000. Generally there is no previous history, fetus is not at risk, and the treatment is not required. Okay, most of the time no treatment is required. While ITP can happen at any time, at any gestation, there may be previous history also. The platelet count will drop more less than 70,000. The fetus is also at risk and the treatment may be required. Okay, so if you have a platelet count less than 70, you may think of ITP. Okay. Now coming to the management of gestational thrombocytopenia, it is a benign condition, so no treatment is required. Just monitor the platelet count. If it is between 50 to 70, you may give the trial of steroids. Okay, so avoid invasive fetal procedures and neonatal platelet check. If the maternal count is less than 80, then only you have to check the fetal platelet or the neonatal platelet. Otherwise, it's not required. So if your diagnosis is firm, the neonate is not at risk, but not this with the immune thrombocytopenia, which we are going to discuss now. So the next category is the immune thrombocytopenia. So this immune thrombocytopenia will have effect on the fetus also. So what happens in immune thrombocytopenia? There are maternal antibodies which are IgG type of antibodies. They are able to cross the placenta. So they will cause the fetal and neonatal thrombocytopenia, and major risk is ICH. Okay, it is rare. Okay, 1% only, but it is a serious risk. Okay, so neonatal thrombocytopenia is seen in these ITP patients in 14 to 37% of patients. The fetal platelet count is seen less than 20,000 in 5% of patients. In 10% neonates, it is between 20 to 50,000. Okay, the risk of ICH is rare, around 1%, and the risk of PUBS complications, that is percutaneous umbilical blood sampling, is around 2%. It is higher than the ICH, so it is not indicated. You don't have to do the chordosynthesis in these patients. Okay, so you can evaluate post delivery these babies, and you can manage post delivery. Okay, no need of PUBS in these patients. So key predictors for neonatal thrombocytopenia will be if the previous sibling is affected, if there is a maternal splenectomy, or if the maternal platelet count is less than 50,000 during the pregnancy. In cases of ITP, then the fetus is likely to get affected. Okay, so important thing, maternal platelet count also does not have correlation with the fetal platelet count. Okay, so that is also one of the important thing you should remember. But generally, if the maternal platelet count is less than 50, then the fetus is likely to affected, but there is no correlation between the maternal platelet and the fetal platelet count. Okay, now what are the things which are not indicated? One is a fetal blood sampling is not, scalp sampling is not required. Percutaneous umbilical blood sampling is also not required, and the fetal scalp electrodes are not to be used. Okay, so these are the things which we are not supposed to do in these patients with ITP. Then what is the mode of delivery? What is the role of cesarean section? Delivery is by obstetric indication only. Okay, whatever is the obstetric protocol, as per that protocol we have to go ahead. So direct cesarean section is not indicated. Delivery mode should be obstetric, not based on the thrombocytopenia. Cesarean section is not routinely recommended. There is no evidence that by doing cesarean section you are going to reduce ICH risk. Okay, so safe delivery practices. Avoid instrumental delivery, especially mid and high cavity forceps or instrumental delivery is to be avoided. Fetal scalp electrodes, fetal scalp sampling is to be avoided, and aim a traumatic vaginal delivery. Okay. Now, neonatal management. At birth, you will inform the neonatal team beforehand. You will take the cord blood for the platelet count. Now, if the cord blood is showing the low platelet count, then what we have to do? We have to confirm the fetal blood sample. If it is a showing thrombocytopenia, then you will repeat the platelet count on day 1 and day 4. If it is normal, no further testing is required. Okay. So this is what ITP can have the effect on the neonate or the fetus also. Okay, so if it is a severe thrombocytopenia, what is the maternal treatment? You can treat with IV immunoglobulin. Okay, then IV immunoglobulin plus platelet transfusion can be another mode of treatment. And if suspected ICH is there, then cranial ultrasound and Doppler. So this is for the neonatal treatment, thrombocytopenia. IVIG can be used. IVIG plus platelet transfusion can be used, or cranial ultrasound. If we are suspecting ICH, then you have to evaluate by doing cranial ultrasound or the Doppler. Okay. Then important thing is that you need to avoid intramuscular vitamin K until you know the fetal platelet count. So that this they can ask in the SBA. Vitamin K should be given orally, vitamin K should be given IV or something like that. So avoid vitamin K until you know the platelet. Get the platelet count, then only you will give the vitamin K. Okay, so
The
important points. Yeah.
reason for not giving vitamin.
No, if there is a thrombocytopenia in the neonate, we will avoid injectable, no, IM. Okay.
Okay, okay, okay.
So,
Both.
important points from the SBA point of view, IgG antibodies are known to cross the placenta. So that will lead to the fetal thrombocytopenia. There is no correlation between the maternal and fetal platelet count. Caesarean section is not as such indicated for prevention of ICH. Percutaneous umbilical blood sampling has got a more risk than the ICH risk. ICH risk is 1% and the PUBS risk is around 2%. Okay, so it is to be avoided. So best predictor of neonatal thrombocytopenia, if the previous affected sibling is there, then this baby is also likely to get affected. So neonatal platelet count, Nadir, generally day 2 to day 5. Classically, you have to test between day 1 and day 4. Okay. So key concept is auto antibodies. They cause destruction of the platelets and will cross the placenta. So this we uh, mat this diagnosis of exclusion is for this our gestational thrombocytopenia that we have finished.
Okay.
Yes, maternal treatment for this is prednisolone. You can give IVIG also. Anti-D also has got the same role as of IVIG, and other rare treatment is a splenectomy and the platelet transfusion. Okay. Now, what are the target platelet levels as far as obstetric is concerned, obstetric management is concerned? When you have a thrombocytopenia, how the platelet count will guide us? Okay, so if the platelet count is more than actually, I think it should be less than 20. Okay, no intervention. Vaginal delivery is permitted if the count is more than 40 to 50. Okay, operative delivery is safe if it is more than 20, and epidural anesthesia is safe it is if it is more than 80. Okay, so epidural cutoff is 80. Okay, 80,000 is the epidural cutoff. This you should remember. Okay, then mode of delivery, it is by obstetric indication only. And what are all the things which we need to avoid? Fetal scalp electrode, mid cavity and high cavity forceps, and no role of cesarean section for fetal protection. This we have seen role of thrombocytopenia and all. Now coming to the hypertensive
Okay.
disorder. So two things we have finished: gestational thrombocytopenia and we have finished with the ITP. Now hypertensive disorders. Okay, preeclampsia, around 15% patients will have thrombocytopenia. It is mainly the endothelial activation that will lead to the consumption of the platelets. HELLP syndrome, we know that there is a hemolysis, increased liver enzymes, low platelets. So you will have more LDH, there may be a rise in the bilirubin, anemia, uh, and there is a maternal risk also. So how to differentiate between the TTP and HUS? Okay, thrombotic thrombocytopenic purpura and HUS. Okay, this also you should remember. Generally in TTP you will have the prominent neurological features, and in HUS you will have mainly the renal
Renal.
features. Okay. This is the clinical feature you should be able to differentiate, because first thing, these are the rare causes of thrombocytopenia. Commonest what we have seen, gestational and ITP. Okay, 75% and 25%. Remaining 5% you have these causes, TTP, HUS, etc. Okay, so in TTP neurological will be prominent, while HUS you will have the renal symptoms or the renal involvement, which is more common. So treatment for TTP is plasma exchange, but there is poor response to HUS, this to the plasma exchange. So platelet transfusion is contraindicated in thrombotic thrombocytopenic purpura. Okay. Now, next is the antiphospholipid syndrome. There is a mild thrombocytopenia. Treatment is aspirin plus low molecular weight heparin that we have seen. Viral and all, generally they are not indicated, not asked, so I will not go into the detail. Okay. Now, this rarely they can ask you fetal involvement. Okay, how the fetals can get affected. So there is a condition called as FNAIT. Okay, so the maternal platelet is normal, but the fetal platelets are destroyed, like RH disease equivalent. So this is something like a RH disease, but affecting the platelet. Okay, so ICH risk is around 26%. 80% cases can occur antenatally also. So most common cause is gestational thrombocytopenia.
ITP.
Most
And
dangerous is TTP and HELP. They are dangerous. If epidural is safe beyond 80,000, delivery is safe beyond 50,000. Gestational thrombocytopenia resolves postpartum. ITP, there is a fetal risk is present. No correlation with the maternal and fetal platelet. Caesarean section is not routinely required. And TTP, there is no role of platelet transfusion.